In this lecture, we will discuss digoxin, including its mechanism, effects, and EKG features at normal and toxic levels. Digoxin is a medication that can be used in multiple conditions, including heart failure, atrial fibrillation, atrial flutter, and some cases of paroxysmal supraventricular tachycardia. It continues to be used in patients that are not fully controlled on other first-line agents. At the same time, digoxin has been shown to have profound pro-arrhythmic effects that can be life-threatening. So how does digoxin work? Well, it has positive inotropic effects, meaning that it increases ventricular contractility, and it also has negative chronotropic effects, meaning that it slows the heart rate. The inotropic effects come from its ability to inhibit the sodium-potassium ATPase in the ventricular myocardium. This results in an increase in sodium intracellularly, which consequently affects the sodium-calcium exchanger such that intracellular calcium concentration ends up increasing. This greater concentration of calcium inside the cell allows for more calcium to be available for the contractile proteins, leading to stronger contractions, and thus a positive inotropic effect. So let's look at this inotropic effect. So here we have our ventricular myocardial cell. So imagine this here is a cardiomyocyte. So we have our cell, and notice here's our digoxin, and what it's doing is acting on our sodium ATPase. So here normally we have 3 sodium that go out of the cell and 2 potassium that go into the cell, and this is active transport, so we require ATP or energy to make this process happen. So what's going on here is we have digoxin that's coming and binding to the sodium ATPase, and what it's doing is also competing with potassium, okay? And if it binds there, what we have is sodium stays in the cell, and because sodium increases, we have now, if you look at this calcium-sodium exchanger over here, okay, sodium will normally, because there's an increase in sodium, will leave the cell, okay? And if it's leaving the cell, we'll have an increase in calcium coming into the cell. That increase in calcium coming into the cell will then enter our sarcoplasmic reticulum, okay, and because of the increase in calcium, we'll have more calcium that can bind these contractile proteins that act in myosin, and because of that, this will lead to stronger contractions of these cardiomyocytes, okay? Remember, here's our plateau phase where calcium is, and that's where we see this effect really taking place. So this is the inotropic effect, okay? Digoxin blocking the sodium-potassium ATPase, allowing for an increase in intracellular sodium. Because of that, we have more calcium that can enter the cell, and because of the increase in calcium inside the cell, eventually we'll have more calcium that binds our contractile proteins, and because of that, this leads to stronger contractions. Okay, so that's called a positive inotropic effect, and that's due to digoxin blocking that sodium-potassium ATPase. Now, the negative chronotropic effects are a result of an increase in vagus nerve activity. This diminishes the automaticity of the sinus node, thereby lowering the heart rate. It also slows conduction over the AV node. Okay, so remember, this negative chronotropic effect, we have an increase in vagal activity, and because of that, it's acting on both the sinus and AV node. If it acts on the sinus node, it's going to slow it down, so we see a decrease in heart rate, and if it acts on the AV node, we'll see a decrease in that AV nodal conduction. Okay, so in summary, digoxin increases contractility and it lowers the heart rate. Those are the main 2 things I want you to take away. Okay, increased contractility, which is the inotropic effects, and decrease in heart rate, which are the positive chronotropic effects, or the negative chronotropic effects here. All right, so what about the EKG? Well, the most characteristic EKG finding is this generalized curved ST depression, okay? You'll hear it a lot if you haven't already. So it's this curved ST depression here, okay? So notice, again, our PR segment used as our reference line. Everything is below our baseline, okay, our J point below baseline, so we have ST depression, and you can notice here marked in red that it's a curved ST segment. Okay, so this generalized curved ST depression is something that we see and really common, the most characteristic to digoxin effects. So earlier we mentioned that digoxin increases intracellular calcium levels. As a result, the action potential is shortened. This means that the action potential of all cardiomyocytes, that is in the atria and ventricles, is shortened and will increase the automaticity in pacemaking cells. This may also provoke abnormal automaticity in cells that do not normally exhibit such automaticity. While arrhythmias can be obviously occur at high toxic levels, they can also appear at those within reference limits. Therefore, digoxin not only has the ability to cause nearly any arrhythmia, but also the risk of arrhythmia is really unpredictable. Okay, so whether we're at normal levels or even toxic levels, these arrhythmias can come about, and it's really any arrhythmia you can imagine. You should also be aware that hypokalemia can potentiate the effects of digoxin. Therefore, serum potassium levels are commonly measured whenever digoxin is administered. If you recall, with our sodium potassium ATPase, notice that we have potassium here, okay, that's binding and going to normally go into the cell. So if we have low potassium levels, imagine it not being here, that allows all the digoxin that we take to bind to that and have even greater effects. So what we say here is low potassium levels lead to an increase in the digoxin effect. Okay, so hopefully that makes sense, and that's why we measure potassium levels in those patients on digoxin. Okay, so just know that hypokalemia can potentiate the effects of digoxin. So let's look at some of the arrhythmias that can be caused by digoxin. We said that digoxin can cause pretty much any arrhythmia you can think of. These are the result of an increase in automaticity as well as a reduction in impulse conduction. So first, let's look at the increased automaticity. This affects both atrial and ventricular contractile cells. It may initially manifest as premature atrial or ventricular beats and are generally considered an early sign of toxicity. As digoxin levels increase, atrial and ventricular tachyarrhythmias can occur, although junctional tachycardia is less common. Now, because digoxin can also reduce impulse conduction, it can lead to a prolongation of the PR interval. AV block may occur and is usually heart rate dependent. Sinoatrial block, which tends to be transient, can also occur. In general, when we look at digoxin toxicity, we'll usually see these extrasystoles or premature beats as well as various degrees of AV block. There's an interesting form of ventricular tachycardia that digoxin toxicity can cause called bidirectional ventricular tachycardia. And with this arrhythmia, the electrical axis shifts from left to right with each beat. Okay, so this VTach is called bidirectional VTach. Okay, and notice that we have our QRS complexes going down, and then you see it going up. Okay, so notice down, up, down, up. See, it's going in both directions. Notice we have wide complexes, a fast heart rate, regular. So this is VTach, and it's bidirectional because we see our complexes pretty much going in two directions, as the name implies. Bi meaning two, and both going the axis shifting from left to right with each beat that you see here. Okay, so that's bidirectional VTach, and that is something that you can actually see with digoxin toxicity. All right, let's review what we discussed and go through this chart to make sure we didn't miss anything. So remember, digoxin increases contractility, which we call those positive inotropic effects, and it also decreases the heart rate, which are the negative chronotropic effects. In terms of the inotropic effects, remember, it inhibits the sodium-potassium ATPase, which leads to an increase in intracellular sodium, as well as consequently an increase in calcium intracellularly because of that sodium or the sodium calcium exchanger. Okay, we have an increase in calcium coming in. More calcium binds the actin and myosin, which are the contractile cells portions, the proteins, and that leads to an increase in contractility of the heart. Now, the chronotropic effects come from an increase in vagal activity. Remember, this vagal or parasympathetic activity acts on the sinus node, which can lower the heart rate. It can also act on the AV node, which decreases AV nodal conduction. Now, in terms of the EKG, we said the most common characteristic feature is this generalized curved ST depression, which we saw here. Okay, this is one you don't want to forget. Now, in terms of arrhythmias, we said that these can be at normal and toxic levels, and they're really unpredictable. And don't forget that low potassium levels can increase the effects, okay? Because imagine potassium and digoxin competing for that sodium potassium ATPase, and if there's low potassium, then digoxin won't have trouble getting in there and increasing its effects. Okay, so these pro-arrhythmic effects are secondary to an increase in automaticity as well as a decrease in AV nodal conduction. In terms of an increase in automaticity, we can see these premature atrial or ventricular contractions, which we said are an early sign of overdose. Okay, you could also see atrial or ventricular tachyarrhythmias as a result of an increase in automaticity. In terms of a decrease in AV nodal conduction, okay, we're slowing conduction through the AV node, we're going to see an increase in PR interval. Okay, so we can see these AV blocks appearing, and they're often heart rate dependent. You can also see sinoatrial block, but that tends to be more transient. Now, in terms of toxicity, okay, we said that these premature beats are an early sign of it, okay, as well as AV block. And then we also mentioned this form of VTAC called bidirectional ventricular tachycardia, where we have our QRS axis shifting from left to right with each beat. Okay, we saw it going down and up with these wide, complex, regular, fast rhythm here. Okay, so that's called bidirectional ventricular tachycardia, and something that you can see with digoxin toxicity. Well, that's the end of this lecture. We discussed digoxin, including its mechanism, effects, and EKG features at normal and toxic levels. I hope you learned something.